Hello and welcome, everyone. My name is Dr. Lasker. I'm a consultant radiologist. I'm just going to give it a few minutes for people to sort of get in, get acquainted, maybe grab your cup of tea, coffees, whatever it is you're going to have at this time of the evening in the UK. Um, yeah, so like I said, my name is Dr. Lasker. Thank you so much for joining us today. We're going to be talking about the long-awaited Neurofellowship that we've been working on in the background for quite a while now. Let's just close this particular screen. Let's see. And okay, good. So it's hit 7 o'clock. So I'm going to just start going. I'm sorry if you can hear that doorbell in the background. It must be a piano teacher coming in. Okay, so let's talk about this Neurofellowship. What are we doing here? So first off, my name is Dr. Lasker, Imran Lasker, a consultant in MSK in trauma. I don't do neuro, not yet anyway. I do some. I'll explain in a bit. I'm really into medical education. You may have seen me on radiology seminars, do some Radiopedia, Collective Minds, done some Everlight teaching as well. I really enjoy teaching. That's what I like to do. So we built this platform, the radiology seminars team, and everything, all to do with the core value of teaching, and that's what we like to do. So I'm going to talk a little bit about my experiences. It's not always everyone's experiences, but my experience of learning and stuff has been difficult, right? Being a radiology registrar was very difficult because often you'd find yourself in a situation with, oh, hang on, there's a question already. Q&A. Can we get CME? Okay, I'm going to let there will be CPD. I think there is CPD. We'll have to get back to that, but get back to you on that one. So yeah, it was very very variable with regards to the teaching that you'd get, right? With anything really, it's dependent on the cases, depending on the trainers, and the volume of knowledge that exists was quite difficult, like to get on top of. And it just depended on the mentors that you have, and also the people that you're working with. Are they judgmental, non-judgmental? And to be honest with me, I like all of radiology. If I could learn all radiology, I would, but I don't think I've got enough lifetimes to be able to do something like that. And so, for what I found was that I'm mainly an MSK radiologist with a bit of trauma. And I found that when I got out into the bad world, the big bad world, I was doing a bit of teleradiology and DGH work. And I noticed that neuroradiology is actually a really, really big topic and something that comes up every day. Every day. Someone has a headache, someone falls over, hits their head, and you try and do the best reports that you can. But at this point in life, it can be a bit difficult to try and upskill yourself, right? It can be very, very hard. Once you become a radiology consultant, you really got to take time out of your day, really dedicate time and go places to try and learn a bit of neuroradiology if you want to get better at it and make sure that your on-call scans, your DGH work is good enough for the patients that you're looking after. So some of the things that you can do. So with MSK anyway, I'm part of loads of MSK groups. These are just some of the MSK groups I'm part of, and you can talk to each other. I'm sure neuro people have got the same thing. Loads of groups, lots of little mini communities. Oftentimes, you're not entirely sure who's who. You're not entirely sure how qualified the person is. You don't know how judgmental they're being because you don't know anyone in there. So maybe you're feeling like you're asking something a bit silly, and then maybe they're going to talk to their friend and say, "Oh well, Imran asked that really silly question. I would have thought he'd know better, know a bit more than that by now." So it can be difficult to get regular teaching. And yes, there are like one or 2 day courses, right? But what we found is that people would come to a 1 day course or a 2 day course and they would learn a lot and then forget a lot. And what we actually find is that having regular teaching over longer periods of time is actually the best way to go. And also having good feedback from a good mentor regularly over a longer period of time is actually the best way to learn. And when you're trying to do pre or post CCT learning, again, it can be very, very variable. You try and go to a course that someone said is quite good. It might work for you, might not work for you. Again, if you're trying to work on the job, it depends on what's coming in and depending on the colleagues that you have. So the question I always ask myself and the way I base most things in my life these days is if things were easy, what would it look like? And so if I wanted to learn a new skill like MSK radiology or neuroradiology, I need to have a comprehensive course, some sort of comprehensive bank of knowledge from trusted people that are knowledgeable, who are not going to judge me because I don't know enough or should know something at this point in time. I don't have time for that kind of thing. You want positive mindset people, not negative mindset people. You want regular teaching. I have some really good cases, really interesting cases that are going to really push me to teach me and also have ongoing support afterwards. Because what we find is that when you have gone to a course, you go into the big bad world and you try and actually do a scan, and it's not like the textbooks, is it? There's always something that's a little bit off about it. And now you're a bit stuck. Like, do I go back to the person to teach me? And I'm stuck in this sort of cycle of like, I don't know what to do next. So I thought to myself at the time, where the MSK community anyway, which is the musculoskeletal community that Radiology Seminars also runs, is I already have access to trustworthy people who are far more knowledgeable than myself, and we built a platform that works. And so we put it out there to ask people: is a neuro fellowship something that people want? And I do have access to trustworthy people who are more knowledgeable than myself, which I'll be introducing in a minute. And we do have a platform that works. So we sat together, we decided to devise a 4 month online fellowship, which is really great because it means you don't have to leave your room. You could listen to it on the way to work, on the way back to work, in your lunch breaks, in between scans. You could listen to learn it. You can watch it over and over again if you wanted to, because online fellowship that we made, right? And this is going to go through everything over 15 weeks. Foundations of neuroradiology, brain, spine, orbits, pediatric brain, spine. I mean, those can get really scary, especially when you're in a DGH or on-call environment for teleradiology. Pediatric brains can come in and you think, oh, I don't know. I mean, I wish I was better at neuro. And then there's some really cool stuff that are coming up, advanced imaging, new things that are coming up, and also the incidental findings that we should be mentioning that we maybe should have learned or could have learned when we were training. So we built this 4 month fellowship together. And so then we thought, okay, so we now got Neuro Fellowship, but then what about the ongoing support? How do we help people with that? And so therefore we use the same thing that we've done with the MSK, the musculoskeletal community fellowship, is put everything together. We built a community, we gave some mentorship, we made a team, we gave opportunities so people within that community are talking to each other, working on projects together. One person even managed to get a job through someone else. Opportunities come from this. And then now, what I want to do is introduce my two colleagues, Hisham and David. They're going to tell us a little bit more because they are the brains, as it were, behind this entire neuroradiology fellowship. They're going to tell us a little bit and also going to give you a little bit of teaching so you can kind of have a bit of a flavor about what they're about and how they teach. And then I'm going to give you hopefully a special offer at the end. So please do hang around. If it's something that you're interested in, you won't be able to get an offer like this anywhere else. So please do hang around. So what I'll do now is hand over to my colleagues and they're going to take over from me. Okay.
Hi there. Thank you, Imran. I'm just going to share my screen in a second. All right. Hopefully you can all see that and hear me okay. I'm going to introduce myself and say a little bit about the fellowship that we're planning to run. My name is David Doig. I'm a consultant neuroradiologist. I work for University College London Hospitals. And my hospital that I work in most days is the National Hospital for Neurology and Neurosurgery at Queen Square in London. It's the biggest neuro centre in the UK, and I'm told by a number of staff. Some people think it's the biggest in Europe as well. So we see a lot of cases, and the idea behind this fellowship is to bring some of the learning that I've had working there to help you improve your own neuro reporting. And so we're going to go right through from the real basics, like just anatomy of the brain and spine, being able to say confidently which gyrus that metastasis is in, or being able to localize something within the spine to intradural, extramedullary, or intramedullary, and really kind of narrow down the possibilities for your differential diagnosis. And we're going to try and take you right through infectious, inflammatory, neoplastic, congenital, all the different categories of diagnoses. What you'll find is that you may find some parts of the fellowship are more useful to you than others. So you might find your anatomy is not bad, but you have very little experience in orbital imaging. So you might have more involvement with that week than other weeks. Or you might find that you've already got a good grounding in the kind of basics of neuroradiology, but what you're really interested in is picking up some of the pediatric or some of the operative spine stuff or things like that. So that's what we hope to provide for you. But there are a couple of things that we cannot provide. One of them is experience in terms of numbers of cases. So our registrars would normally report about 1,000 MRIs, 1,000 CTs, 1,000 X-rays per year. And so what we're going to try and do is, instead of giving you large volumes of cases, we're going to try and give you some tips and tricks that can be kind of applied generally. So you see there's a session at the end that Imran mentioned on incidental findings and how to manage them, and just really those kind of common day-to-day scenarios. The other thing that we'll give you, obviously, is that kind of support in terms of the community as we go along. and the reassurance that this is learning for you without any kind of examination at the end. So there's nothing to study for. You can just make the most of the experience as we go along. And to give you a kind of preview of that experience, what I'm going to do now is try and persuade you that even if you've never looked at a perfusion CT before, in 10 to 15 minutes, you can start to interpret these studies. So this is a talk that I gave to our radiographers earlier today on stroke perfusion CT. Which is an advanced technique that we use to identify stroke patients presenting late who might have ischemic brain tissue that's not yet dead that might still be saved. So they would be outside of the normal time window for thrombolysis, clot busting therapy, or thrombectomy, mechanical clot retrieval. But even though they're outside that time window, they might still benefit, and that treatment might save them from death or disability. The other group of patients who you might use perfusion in is patients having a wake-up stroke, which means that you don't know when the time of onset is. So it could have been 5 minutes after they went to bed the night before, it could be 5 minutes after they woke up. And what we're doing with the perfusion is working out who might still benefit from clot busting or clot retrieval therapy. So this is, in the UK, the National Optimal Stroke Imaging Pathway. We'll ignore this limb that mentions MRI so far, because actually, in most centres in the UK, this is an aspirational thing, doing MRI for acute stroke. The vast majority of patients will go down this leg here, where they have a clinically suspected acute stroke. They'll be delivered to a stroke centre or somewhere that can do stroke imaging. And within 20 minutes, they'll get a plain head CT and CT angiogram. But then if they don't, on the basis of that or on clinical criteria, meet the threshold for IV thrombolysis, we will then consider CT perfusion. So that would be, in our case, patients presenting between 4.5 hours or 12 hours after the onset of their stroke, or they wake up with stroke symptoms and the midpoint of their sleep was less than 9 hours ago, which is going to be most people. If we want to understand stroke perfusion, we've got to understand what's happening in the brain. So this is a bit simplified, the next couple of slides, but really we're looking at cerebral blood flow, which is measured in mils per 100 grams of brain tissue per minute. And that cerebral blood flow is what delivers the oxygen and glucose to your brain cells. So if you have 50 mils of blood flow per 100 grams of brain tissue per minute, your neurons are quite happy they have enough oxygen and glucose to survive. If that drops down, say, to about 40 or 35, you can kind of compensate for that in a couple of ways. So your brain could increase the amount of oxygen that's extracted from the blood, the oxygen extraction fraction. You could vasodilate up a little bit, so you could dilate the arteries and veins and try and improve blood flow that way. But as the blood flow continues to drop down to about 20 mils, then the brain will find it increasingly difficult to compensate, and the tissue will become ischemic. So that's tissue that's at risk of dying. And how long you can tolerate that depends on how severe the ischemia is. Below about 20, you'll have electrical failure of the cell, and you will definitely have signs and symptoms of stroke at that stage. And below 10, the cells don't have enough ATP anymore to maintain the membrane pumps, and so the cell swells up and it dies. And how long you can survive with each reduction in cerebral blood flow is really dependent on how severe the reduction is. So you imagine the scenario, you've got a cardiac arrest, there's no CPR happening, you have 0 mils of blood flow per 100 grams of brain tissue per minute, and so all your neurons will be dead in about 10 minutes. Where this 4 to 4.5 hour time interval comes in is really when you have more modest reductions in cerebral blood flow. Those neurons can hang on for quite a long time, for a few hours, but eventually they will die off. So our CT perfusion is identifying what is core infarct that is already dead and what is penumbra that might be saved. And how we do it, we have a patient with a cannula in, we've done our plain CT head, we might already have done our CT angiogram as well, and then we're going to give a contrast bolus through the power injector, followed by a chaser of saline to push all that contrast through, and we're looking at each voxel in our CT in the head and looking at the contrast density. And obviously, as that contrast comes in, the density will increase, and as it washes out, the density will decrease. So there's a bit of a time lag while that contrast circulates around your heart and up your carotid arteries, and then the blood flow comes into the brain. So the cerebral blood flow is related to the steepness of this curve, this increase in Hounsfield units. The time to peak is how long it takes to get to the maximum contrast density, and then we see the contrast wash out, and we get the cerebral blood volume by looking at the area under the curve. So there's some maths involved, and we'll kind of come back to that. So how do we interpret that then? Well, obviously cerebral blood flow is related to the amount of blood going through over a certain time. Within the core infarct, the cerebral blood flow will be severely reduced. The time to peak will be increased, because if there is any contrast coming through, it's either trickling through a 99% blocked artery, or it's coming via collateral pathways like anastomoses from the dura or the anterior posterior circulation. The cerebral blood volume will also be severely reduced. In the penumbra, what's happening? Well, we said there would be only a little bit of a reduction in cerebral blood flow. There will still be prolonged time to peak. And the cerebral blood volume, well, actually, several things could happen with it. Could be slightly reduced, could be the same as the other side, or actually the cerebral blood volume could paradoxically be increased. And that is your brain doing exactly what we just discussed. It's vasodilating to try and make the most of any blood that is getting through. So the thresholds you use to generate the maps of what's core and penumbra will depend on which trial you're following and which software you're using. We use relative cerebral blood flow of less than 30% of the contralateral side to be the core, and a Tmax of more than 6 seconds denotes the penumbra. So when I open up my CT perfusion scan, I want to check that it's kind of technically adequate to start with. So is the patient positioned correctly? Have we got the correct region of the brain? Is it too low or is it too high? And has the software selected the correct input and output vessels? So you'll see here, it's got a little plus sign on the anterior cerebral artery. So I'm happy with that. And we see an arterial curve in red that goes up and down and washes out. Very nice. We see an output vessel with the minus sign, which is the straight sinus and the torcula. We see a venous curve in blue. Nice. This tells you about whether the patient has moved, rotation, and translation during the study. None. So that would be a perfectly technically adequate study. But there's a whole bunch of other potential pitfalls to consider as well, which is that if you took one stroke perfusion data set and went around 6 different software manufacturers, you would get different results from all of them. So we have to interpret it in light of the non-contrast CT, the CTA, and most importantly, the patient's actual clinical symptoms. The software needs to select the correct inflow and outflow vessels, which does not always do. Patient motion and bad positioning can affect the results. And if you have stenoses or narrowings in other arteries elsewhere in the head and neck, it can kind of confound the results, because you imagine we said we were looking for a relative reduction compared to the contralateral side. Well, what if your arteries are abnormal on the contralateral side? Then it becomes very difficult to make that comparison. And you've got to remember that the reason you want to know the patient's symptoms are that findings are also abnormal in other diagnoses. So if you have an old infarct, perfusion will be reduced, but you're not having an acute stroke. If you have a tumor, perfusion might be increased. And migraine and seizure can be different depending on what stage of presentation you're at for that. So that's all I have to say in terms of a sort of primer for perfusion. But if we go on to have a look at one or maybe even 2 cases, just to illustrate that, hopefully you can start to appreciate what we're talking about. And we'll try to get a little bit interactive, if you like, in the chat. If you feel comfortable commenting on the case, let me know. So this is a patient who's presented at 5 hours post sudden onset of a left-sided weakness. And the first thing I see on the CT, even though it's the fixed slices, I can see that there's a dense right middle cerebral artery. So if I land on this slice here, maybe, we can see, hopefully, even though it's via Zoom, you can see that the posterior part of the insula, you've lost gray white matter differentiation, and that actually you can't see the basal ganglia on this side. So in terms of the anatomy, here's the caudate nucleus, here's the lentiform nucleus, and both of them really hard to pick up versus the other side where you can see them right well. But most of the middle cerebral artery territory, which is also something we'll cover in the course, is vascular territories. You can see the grey-white matter differentiation, you can see the cortex and the white matter quite well. So already I get the idea that this patient might have an MCA occlusion and might have a bit of an established infarct already. I'll then go and look at my CT angiogram, and hopefully there's some thick images supplied here. So here's the normal left middle cerebral artery, filling its distal branches quite nicely. And here's a very abrupt cutoff of the right middle cerebral artery. So what we're here for is the perfusion. If we have a look at that, you can see that the patient is squinting the scanner. So this is not a great comparison, comparing a bit of bone, the temporal bone on the right with a bit of brain on the left. But it's good enough in this case because actually you see that the relative cerebral blood flow, where cold colors are bad, there's a severe reduction in cerebral blood flow in the lentiform nucleus and the caudate on that side. And cerebral blood flow is actually preserved in much of the rest of the MCA territory. If we look at the Tmax, we were saying that was going to kind of donate the area of penumbra. It's longer than 6 seconds. So again, cold colors are bad. Almost right throughout that whole MCA territory on the right. So if you feel comfortable saying in the chat, you can tell me what you think. Is this someone that might be a good candidate for thrombectomy or thrombolysis? In the meantime, while you're thinking about it, I will show you this mismatch that's automatically calculated by the software. You can see there's a red area here, which is core infarct, and green, which is penumbra. We have an answer saying, yes, suitable candidate. So this is ideal. Assuming that clinically they're okay to have the treatments, this is a small core and a large penumbra. Okay, I think we'll probably have time to show you one more case, which you can imagine might be a counterexample. So here we have some deviation of gaze to the right, although I would always be careful about over-interpreting that because sometimes the patient's just looking at something. But in this case, I think it's because there is a very large right MCA territory infarct. So you see the basal ganglia this time are preserved and the thalamus is preserved, but actually most of the cortex on this side is gone. So we've got the early signs of stroke, we've got loss of the insular ribbon, we've got loss of cortical, subcortical grey-white matter differentiation, and actually you've got some swelling as well. So we see lots of sulci on the other side, good volume of brain, a younger patient, but on this side we've got some parenchymal swelling, which means those sulci are effaced. And again, if I go right down, even though it's the thick slices, I've got a suspicion that there might be some arterial clot from that density. So we look at our CT angiogram. We can already see up here in distal portions of the MCA territory, if you were to do a little vessel count of the right compared to the left, we'll look at all these M3 and M4 left middle cerebral artery branches. I don't see any corresponding ones on the right. So this is probably a patient who's got a proximal occlusion and pretty poor collateral blood supply. And we come down and we see that it's a distal right M1 segment of the MCA occlusion with poor collateral supply. So again, I know the patient's symptoms. I've seen the non-contrast CT, I've seen the CT angiogram. I already have an idea of what to expect on the CT perfusion. And if we just look at the maps, what's going on here? Well, we see cerebral blood volume and cerebral blood flow are severely reduced almost throughout the entire MCA territory, with a little bit sparing of the basal ganglia. That's because those are supplied by the proximal portion of the MCA that wasn't occluded. And there's little perforating branches that come off and supply the basal ganglia. Tmax, time to peak, we said donates the penumbra. Well, it is prolonged throughout almost the whole of the MCA territory again, but unfortunately for us, that Tmax prolongation matches what we see in terms of severe reduction of CBF and CBV. So when we look at our mismatch is what it looks like here. We're seeing the software calculate a large area of core infarct in red, and some small areas of penumbra in green. So there's one comment that this patient is not a candidate for mechanical thrombectomy. I would agree. The aspect score is too low if you use that, and there is only a very small amount of penumbra in the brain to save. What you see, that this is kind of what you get in real life. The model is usually you see a sort of sphere of core infarct and another bigger sphere around outside of penumbra, but that's not always how it looks in the mismatch map. And sometimes you just get small bits of core and small bits of penumbra, but we take the overall kind of context into account for the patient. And there was a question about whether the software is saying there is a mismatch. The mismatch ratio would be very small. So the area of penumbra to core would be very small. So this isn't a patient that we would select for thrombectomy. Okay, so hopefully that's persuaded you that some of these kind of exam advanced topics can be kind of broken down into a few more simple steps, and that by kind of working through those examples, we can start to get a handle on it. And that's really the format for the course, is that you'll have a little kind of video review, a little bit of teaching on a topic, and then you'll be able to look at some interactive cases with one of the tutors where you can go through your findings and your diagnosis and see how it matches up to perhaps a final histological diagnosis, and what imaging features or clinical information we would use to try and work that out. Thanks. I'll hand over to Hisham now.
Thank you, David. Thank you very much. That was very helpful, to be honest. I learned a lot from this. Hello, everyone. My name is Hisham Jeba. I'm a neuroradiology consultant. And 1 second, let me just share my screen properly. Here we go. Brilliant. I'm neuroradiology consultant in South Wales. I mainly work in the University Hospital of Wales Tertiary Centre. It's a trauma center. It's also a center, a neuro-oncology center. We have a big neurosurgical department in there, and I also work in a DGH, Princess of Wales Hospital. I provide tertiary opinion in there. I'm also academy trainer in the National Imaging Academy of Wales, and I am the training program director as well. As you saw and learned from David, neuroradiology is a very interesting specialty. We will try to cover a wide range of topics. I named a few in here to cover some of the weeks. What drew me to this specialty is the wide range of interesting and beautiful signs that you can see in the brain that you can link to other specialties and link it to diagnoses as well. Like for example, if you're looking for progressive supranuclear palsy, you have this hummingbird sign and Mickey Mouse sign and all of that. So that really draws my attention, and I try to focus on these signs when I teach my trainees to make the specialty interesting and to help them remember things. And I'll give you this little example, a little teaser. When I talk about toxic metabolic conditions, as you can see here, on the right, you can see a skull with a beard and a big mustache. And you can actually imagine this when you look at this T2 axial slice through the cerebellum. You can see the dentate nuclei, normal, but you have a lot of edema and swelling in the cerebellar tissue adjacent to it, extending to the middle cerebellar peduncles and involving the spinothalamic tracts. So this bearded skull appearance, skull with a beard, you see in certain condition, which is inhaled heroin toxicity. So when you see this appearance and it's linked to this diagnosis, it makes things really easy when thinking about neuroradiology. And there are other signs that we can link to other diagnoses as well. During the fellowship, I will talk about neuro-oncology in details and the tumors that can affect the brain. Talk about pseudo progression and true progression and these topics that some people might find challenging, and still sometimes even if you know everything about them, they can be still challenging. So when we develop in the future the community, you can ask us questions, we can help each other and try to narrow things down and make things easier when it comes to pinning down a diagnosis. I have a case to show you. It's a neuro-oncology case. Let me see. So if I stop sharing here, 1 second, here we go. And if I share this screen, here we go. Beautiful. Alrighty. Let me move this part of it because that's case number 1. Brilliant. Okay, so this is a CT, relatively young patient in his 50s, who presented with confusion and headache. Complained of headache for a few days before presentation and then confusion. So the family brought him to the hospital, and the A&E department, rightly so, requested a CT head, and the CT head showed these appearances. So as you can see, there is edema in the right side involving parietal, occipital, maybe bits of the temporal, occipital, and bits of the parietal lobe as well. And you can see this relatively high density mass around the right peritrigonal region. Do you want to have a guess on CT, or shall we go for the MRI? Okay, there we go. So we have, all right. So there are some answers coming. Okay, brilliant. All right, so let's have a look at the MRI. So the MRI gives you this appearance on the T2 axial images, relatively low density abnormality in the right peritrigonal space, and when you look more carefully, you can probably see some lesions around the frontal horns as well as in the around the left lateral ventricle. And when we talk about these tumors in the fellowship, we will focus on the importance of ADC sequence. People run straight to DWI, but ADC is very useful sequence. As you can see here, you can see this abnormality is slightly dark on ADC, so that is restricting other foci, other areas around the ventricles that look really dark. So they are restricting, and obviously when you give contrast and have a look at these lesions, they're all homogeneously enhancing. So as it was mentioned in the comment boxes, this is multifocal CNS lymphoma. And we will learn that there in infiltrating crossing the splenium, choroid papilloma. Yeah. Okay, interesting. Okay, interesting. Yeah, the answer, the comments I'm looking at are interesting, because yes, it is trying to cross, or well, it is crossing. It's on the other side, not just on one side. And during the fellowship, we will learn why this is lymphoma and not a GBM or high-grade glioma. And we will see the difference between them. And sometimes some cases catch you. They will look like typical high-grade glioma, for example. When you get a biopsy, it will be lymphoma. So there are some tricks and some features that you can see on MRI that will help you diagnose this and try and pin it down, as we said. Lots of cases, lots to learn from. David as well is an amazing teacher and educator. So I hope you join us and learn a lot from this fellowship. I'm happy to take any questions if there are any questions or not. Imran,
Yeah,
if Imran's still
yeah,
around, here we
yeah.
go.
I don't see any questions. So what I'll do, I'll just go through the rest and just introduce what we're doing. So yeah, first off, thank you so much for those who've interacted. It's really, really good. That's what we like to see. It always shows that people who interact are a lot more likely to learn. So that's really, really good. But as you can see, we've got some really good cases. Fantastic teachers as well that we work with at radiology seminars. That they've been working with us for many years, and we've been able to help a lot of healthcare professionals kind of upskill themselves. But this is a very sort of newish concept that we're putting together, and we use a platform called Circle. And this is exactly how it works for the MSK community, where you can kind of log in and you can just see what's going on. You've got access to the fellowships here, and you can have a proper like Facebook style discussion. But because it's a closed group, right? We know who's in, we know who's out. We can vouch for people who are in there, and we have regular sessions. We've got events and courses that are all available for people. Everything's recorded so people can catch up in their own time. Like I said, watch things and on the drive, catch up with things as they happen. This is what it looks like on mobile. So mobile's been absolutely amazing using Circle, because sometimes you'll have a case and you take a video, obviously anonymized, put it on the group and say, listen, guys, I'm not sure what this is. Any ideas? And people discuss it. It's for teaching purposes. We're all trying to learn from one another. No one judges anyone in the MSK community, and that's what we're trying to build for neuro as well. This is mainly, it does look like it's mainly me. Yeah, it pretty much is me in the MSK community asking lots of questions because I don't know everything. It always feels like there's so much more to learn. And I'm sure there'll be other people out there that will also feel like there's a lot to learn. And then here you see like, yeah, we upload cases. Some of this are just photos on the phone and put up there and things like that. And then you got access to the community fellowship programs. And then people have been asking other things. So we update that quite regularly. You can see your progress as you go through. And so this is the great. I mean, this has been working really, really well for people. And I think we've looked around and no one really offers a combination of a full-on fellowship, which goes over many months like this, and also have the sort of live interaction, being able to ask questions about the cases that are coming up that you're not entirely sure about, that don't quite fit the textbook answers that you get. So it's all online, which is great. You don't need to travel anywhere. You don't need to sit with anyone. You could just keep up with it, keep on your phone, listen to what's going on in the background. It's all self-paced as well. You can go at your own pace, ask questions of the tutors as you go along. And then we're evolving. It's a learning environment that evolves. So with our one in particular, I bookmark things that people have talked about. I highlight things that people have talked about. So sometimes I'm in the middle of reporting and I remember, oh yeah, there was that measurement that someone talked about. I go back, I do a quick search, I look at my bookmarks and it's there. So it ends up being a really nice evolving environment for people to learn from one another. It's just an example of what it looks like when you are logged in. This is just 1 week of a minuscule lecture, and you've got all of it on the sides. It shows your progress, and you can go through it as many times as you want. Again, we use a really good online platform to be able to use full DICOM images, so you can kind of look at it properly, have a look, and see what you think, and go back to the videos and see what the tutors are saying. Again, this is what it looks like on mobile. You can just take photos, and again, just like Facebook and any other social media platform, you can just look through like this. And actually, to be honest, since I've been finding X quite difficult to deal with because Elon's been a bit weird, I do find myself scrolling through the MSK community, just seeing what's going on, learning a few things, bookmarking things. It's kind of weird. It's like a bit of a nerdy MSK community that we're now building for neuroradiology. So if you're into neuroradiology and just like to have a bit of fun and discuss things and learn from each other, then this is really, really is for you. And this is how we do it. You just take a photo, upload, you can see almost see my reflection there. Take a photo, put it into whatever space you want, and then see it. And that's the thing. We will have is a community manager. They will consistently link articles, link websites, link any discussions so that people can find it. It won't be quite many, it'll be mini discussion style. We kind of can bring cases to the platform, have a look, have a chat. It's open to all the members. They can go through the cases, go through previous imaging and all the rest of it. It's not like Fight Club, yeah. I don't know if anyone's into that film anymore. It was a film that I used to love as a kid. You can tell people about it. It's not like a closed group like that. You can go tell your friends and your friends that there is a neuro radiology group that exists, and maybe be something that'd be in for. But like I said, we maintain some sort of exclusivity because we want to know who's in there. We want to know people that are serious. I've been in Facebook groups where it gets spammed. You're not entirely sure what the other person's talking about. You end up getting in arguments. It's not worth it. With a closed group like this, you kind of know who each other are. You can actually help each other. Like I said, people right now are working on projects together and that kind of thing on the other platform. So yeah, the main thing is you get regular access to the case rundown, you get access to all the pre-recordings, you get access to all the cases, you get access to the actual fellowship itself, which is pretty formidable. I have to say, I wish this existed when I was a registrar. I'm not even MSK, I'm not even neuro, but I'm going to probably be on this as well, because I find that a lot of neuro affects everything. Like you're in DGH and you need to look at these scans and stuff. So a bit wordy, but this is pretty much what we have. And as time goes on, we're going to start getting monthly speakers. So we'll get people from other university college hospitals and all that kind of thing to come in and give us the talks, tell us about their field, tell us about their research, talk about things that they could get involved with and that kind of thing. So I think this is a really formidable thing, and you can go out, you can have a look for something similar. I don't think you'll really find something at this price point as well, where you get full access to the entire fellowship and have community support from one another and some really, really well-renowned individuals, Hisham and David, who are very good teachers and been working with us for a long, long time. So I did promise that if anyone did hang around, they'll be able to get access to a very special offer. I highly recommend that you do decide to go for it. So what we're going to do is give you guys the opportunity to sign up now. We'll be launching early, so this is kind of an early bird offer. We'll be launching it sometime in January. You can save 20% on the monthly or the yearly subscription. The good thing about this as well is that some people are really quick. They just get through things really quick. So if you just want to sign in for a month, do all the fellowship and leave, then fair enough. Some people dip in and out, which is fine too. The point is you learn at your pace, whatever level you're comfortable with. We can also do institutional access. So there have been occasions where we've got a group of people who come together saying, look, we all want to be part of the community. Can we work something out? And we do. We want it to be open as much as we can without having it polluted, as it were, by having people who are not actually that interested in learning from one another, and also people are not going to be positive mind frame, positive mindset, try and help each other, not be judgmental about the questions and things that come up in the conversation. So yeah, if you do go to the website now, and if you are interested or you want to have a quick conversation, do check out radiologyseminars.com. If you just want to go for it, Neuro 20 is the thing to type in when you go. You can scan this in and go get yourself a 20% discount and hopefully be part of what is going to be very, very exciting. I expect it to be very sought after. The waiting list is huge for this. It really is. I was very surprised how many people are interested in this. So do try and get in early, because if it gets too busy, you may need to just kind of limit the numbers that are going through in the first instance on the first wave of people. So please don't miss out. If you have any questions, do put them in. If not, then I guess that would be it from ourselves. So I'm just going to have a look at any questions, Q&A. No, good. So the recording of this will be available later. So if someone's missed it or you wanted to give it to someone that may be remotely interested in something like this, please do send it around. Please do share it. And maybe later on in life, maybe it's not the right time for you, but at some point in life, you may suddenly find yourself a little bit lonely and you want to have a bit of help in your MSK, your neuroradiology stuff. And this may be exactly something that you need. So yeah, we're always available, always there. Prerequisites for turning up and being part of it. Ideally, you want to be a radiologist. But we haven't stipulated. So basically, yes, we know there are other people that may be interested in some kind of fellowship like this, like neuro consultants and neurosurgeons, and sometimes you even get yes, you get radiographers who may be interested in this. So as long as you are interested, so the main ethos of radiology seminars in general is to try and teach anyone that is remotely interested in imaging, because we believe that imaging is the forefront of medical care. Anyone who comes in is going to get some sort of image at some point. So I think at any level, it is good to know some level of imaging. So you every patient will get some sort of scan on some level at some point, and that's why I think that's what radiology seminars are built on. So yeah, DICOM images cases will be available for the Neurofellowship. Exactly. Yeah, and for the community. So if you are part of it, then you will be able to access. So once you're in the community, you get access to all the DICOMs, all the videos, all the time, all the time. Obviously, if you leave the community, then fair enough. Like you won't access everything. Yes, they can be paid in installments. I would recommend thinking about doing the monthly, but yes, you can do installments as well. And we do, and we work with a lot of NHS trusts at the moment as well. So we are on the NHS framework. So if you do think it's something that may be useful that you could get through work, then we can definitely open up that conversation as well. But yeah, monthly membership and installments can be done as well. And DICOM images are available once you're in there. The other thing I'll say, which has been really good in the MSK community, is that because we support one another, sometimes I'll put a case up and then we have a prof on there and he said, Imran, can you send me that case because I want to use it for my teaching? And we always go in with, as long as it's anonymized, which it always is, we do police it. then everyone's able to use the image, whatever it is, right, for teaching. And also, what we did is make it so that we actually were able to send a zip file of anonymized JPEGs to that professor so he could use it for a talk that he was working on. Another question popped up. Any offers for Wales consultants? Of course. Let's open that conversation. Let's do it. Look, I think these things are evolving and these things are changing. And I think that what you'll notice is that community-based learning is very, very powerful. And I think it's something that's missing on the online environment. I think we all kind of go to these one-day courses and feel like, okay, we're done now. But that's not how we all learn. I mean, we all learn in classrooms, we all learn in hospitals, we all learn with other registrars, we all learn with each other. And so this is what we've done now. We built this and it works. It really does work. And it's worked for me. It's completely changed my reporting and completely changed the way that I feel about when I see a difficult case. I know I've got a team that are going to not be judgmental, and I put a photo up, say, look, guys, what do you think? And then they'll discuss it or just tell me, actually, Ryan, that's what that is. And that's a link to the article. Go have a read. And then I bookmark it. I know it from now on. And genuinely, my MSK, I thought was all right, but it's definitely increased in, like, I've definitely got a lot better over the last few months of having the MSK community. And I have no doubt we can do the same thing with the neuro community because I think there's a lot of motivated people out there that want to help each other and learn from one another. So I think those are all the questions. I think I've answered everything. So with that, I say thank you as always, because at the very least you've given me your time and I appreciate that. I hope you gained something from some of the things that we've taught, and maybe we'll work with with one another at some point soon. All right. Till next time. Bye.